My name is Kathleen Newbould. I'm the Education and Support Manager for the Northwest region of the Crohn's and Colitis Foundation. I'm so happy you all are here today, and I'm so happy that we're having this pediatric conference. This is something that we haven't done in quite a while. So it's something that we've been wanting to do forever, and it is a special project to the staff here at Children's as well. We're partnering with Children's for this program. And I want to thank them for all of their help and support putting this together, especially Teresa Walks. I don't know if she can hear me, but she is a special lady and a great volunteer for us, so we thank her. A couple things I want to point out. You should each have gotten a program folder, which has copies of the presentation, so you can follow along. And you've also got a program evaluation. We ask that you fill that out and turn that in before you leave at the end of the day. For the kids and teens, they'll be breaking off after the first two sessions. That'll be at 11:10 a.m. Each of the kids should have gotten a piece of paper at registration that says, something. It's questions you have about the presentation. So take notes, and we'll get those questions answered in the separate session. The restrooms are down the hall to the right, and I hear there are also some around to the left. So feel free to get up and use those if you need to. So I would like to introduce Carin Murray. She is the Division Chief of the Pediatric Gastroenterology and Hepatology Program here at Seattle Children's Hospital, and she's the Program Director of Gastroenterology Education. She is a professor in the Department of Pediatrics at the University of Washington School of Medicine, and she received her MD from Johns Hopkins School of Medicine and did a pediatrics residency and a chief resident year here at Seattle Children's. Thank you so much, Dr. Murray.
Thank you very much. And I actually have the exciting role of introducing the morning, kicking things off, and really welcoming you. We're so pleased that you are here. This day is sponsored, as I assume you know, by the Crohn's and Colitis Foundation and the Northwest Chapter in particular, and is co-sponsored by our institution here at Children's Hospital. And we're putting it on. Our Inflammatory Bowel Disease Center members are putting it on, and we're really truly excited that you are here. You're here to learn, have fun, and to partner with us in improving the care we can provide for inflammatory bowel disease. So, with no further ado, I will figure out how to work this. All right, so as I said, we are hoping that you will learn quite a bit. We have an exciting program, and I will review this, although you've seen the schedule. We really hope that you have fun. The kids have their own program, and Teresa Walks is orchestrating that. And I think they will not only learn quite a bit about inflammatory bowel disease, but they'll enjoy themselves as well. I hope the same is true for the adults. We would like, for those of you who don't know us, to meet our inflammatory bowel disease team. We think we have a really great team. There are other great teams in the area. And we strive to be the leaders in inflammatory bowel disease for our region. And we really want to partner with anyone who wants to partner with us to learn more and take care of inflammatory bowel disease. Pictured here are a number of individuals who you will meet as the day goes on. Standing at the top is Dr. Ghassan Wahbeh. You'll meet him shortly. Teresa Walks, who's sitting in the back of the room and will be, is one of the organizers, really the main organizer for the program today. Amanda Bradshaw is one of our nurse practitioners, and Dr. David Suskin is sitting in the front. We have other members, and you will meet many of them, including other nurses. Heidi Monroe is here. Dr. Carin Cunningham is one of our psychologists. We have social workers. Nyla Gregory, one of our many nutritionists. As you know, those of you who have inflammatory bowel disease, this is a condition that not only requires the input of physicians, but also is really a multi-specialty disease, and we strive to take care of the entire individual. Above all this, we hope that you're inspired. We want you to learn a lot about the disease, the inflammatory bowel disease, and really be able to be excited about the progress that has happened in the last 5, 10, and soon to be future years in the care we can provide and the knowledge we have. So, this audience, I don't have to tell, because you already know that autoimmune conditions are on the rise, and this has been true over the last number of decades, as you can see in this chart. Inflammatory bowel disease is no exception. You can see Crohn's disease here at the top. This is true for ulcerative colitis as well. And we really want to start impacting this increase and providing not only care to those who suffer with this disease, but also try to prevent it for the future. Currently, there are about 1.4 million individuals in this country alone, the United States, who have inflammatory bowel disease. About a quarter of inflammatory bowel disease occurs in childhood, and about 100,000 children in the United States live with inflammatory bowel disease. This translates to approximately 5,000 new diagnoses per year nationwide. And alone at Children's Hospital, we diagnose 1 to 2 individuals per week. So in order to start impacting this, we need to understand the disease at a very deep level. And I don't simply mean to say Crohn's disease influences the terminal ileum and colon most commonly, and ulcerative colitis is limited to the colon. I mean really understand the distribution of the disease in populations and understand why the inflammation goes awry that causes the illness in individuals who suffer it. So let me show you an example of what I'm talking about. And we get this kind of information through research. So here's a world map looking at the prevalence or how common inflammatory bowel disease is in different countries. And as you can see, for those of you in the room who may not have memorized yet the world map, this is Canada. Our fine country is right here, the United States. We're sitting right about there. This is Alaska, and this is Europe. You will notice that the countries where inflammatory bowel disease is the most common, namely the red ones, are also the countries that have been termed the most developed. We have the most refined food, we have clean environment, we have very few, relatively speaking, infections, and we don't suffer, for the most part, bad, life-threatening diarrhea in childhood. The countries that are in blue, on the other hand, are just the opposite. And this is, I'm somewhat generalizing, obviously, but these are countries where they do suffer more enteric infections, and their food may not be as refined and clean as we are able to benefit from. What does this say about inflammatory bowel disease? Well, these are the questions that we ask, and you'll meet this gentleman shortly. He's sitting over here to my right. This is Dr. Wahbeh, and he is pondering these very questions to try to understand why exactly inflammatory bowel disease is the way it is. These pictures, by the way, are from Camp Oasis, for those of you who have or have not been there. Over the last number of years, there have been huge advancements in inflammatory bowel disease. We now know specific genes that help suggest whether an individual is going to have a higher risk of getting the disease. It may influence the way the disease presents in that individual. We also know that this is an autoimmune condition, and specifically, we know details about how the immune system in the body as a whole, but specifically in the lining of the intestine, what we call the mucosa, hence the mucosal immune system. What that immunology is doing. How is it interacting with the rest of the body outside of the intestine, and how is it interacting with the luminal contents, the stuff that's in the intestine, the stuff that it's exposed to. And then, of course, that quickly dovetails to the environment. So we live in an environment, I just showed you a picture of the world, where the environment, depending on which individual you are, is slightly different as far as your food, what bacteria may be in your intestine, and what kind of air you breathe. These are very important. We also know that stress plays a huge role in inflammatory bowel disease, and this is not a secret. Those of you who have inflammatory bowel disease most likely know that stress, whether it's excitement or whether it's anxiety or whether it's just angst about something else, can influence the disease, whether it flares, does it go into remission. And we need to understand that at a deep level so that we can influence it. And Carin Cunningham, our psychologist, pays a lot of attention to this, is trying to understand it better through her research, and we'll share what we know with you. We use medications. We use a lot of medications. We do so to try to target various aspects of this disease. You're familiar with many, and Dr. Singh is going to speak about these later, that are anti-inflammatories targeted at that immune system, trying to decrease the inflammation. We have immune modulators, things that decrease the way the immune system works in general. Azathioprine, Imuran, methotrexate may be examples of that, Remicade. We have medications that can target specific molecules like tumor necrosis factor, hence Remicade and Humira. And these are all very potent immune modulators in decreasing the inflammation that is awry. But what if that doesn't work? We also have therapies that may be medical, may not, for instance, surgery, and that plays an important role, unfortunately, in our care of folks with inflammatory bowel disease. And then what if we really completely turn the immune system upside down? The immune system is the problem, after all. What if we just replaced it? And we did a bone marrow transplant. Seems a little severe. However, individuals who are really suffering with this disease may actually benefit from that. And there's a trial here at Children's going on regarding that. The intestinal microbiome. So we are a house, if you will. We are the harbingers of a huge number of bacteria. There are actually more bacteria in our body than there are cells in our body that are ours. They're on our skin, but most commonly they're in our intestine. And we need them. Without them, we don't have vitamins. We can't digest food. We have a real problem. So we do need them. However, we also know that the intestinal microbiome in folks who have Crohn's disease, who have ulcerative colitis, are different from each other, and they are different from those of us who do not have inflammatory bowel disease. Why? Is that a secondary effect? Is it a primary effect? There is research going on that is helping us to know that. Can we influence the intestinal microbiome? We've been doing this for decades. We use metronidazole or Flagyl, an antibiotic, in the treatment of Crohn's disease. It can be very effective in some individuals, goes up in the medicine pod there. But it is directly influencing the intestinal microbiome, which is in turn influencing the inflammation. So this is a very important area of research. And then not lastly, but lastly for this slide, is diet. So there's been a lot of growing research over the last just few years about dietary influence on inflammatory bowel disease. We now know that diet, what we eat, influences the intestinal microbiome, namely the bacteria that are in our bodies. If you look at the world, if you look at populations around the world and you look at their diets, they're highly different for cultural and regional reasons. And that probably has some influence on the bacteria that are in there. It therefore makes sense that it may very well influence the immunology and hence the potential for inflammation and being able to target different inflammatory changes. So there are a number of diets that are used and under research. Liquid diets for inflammatory bowel disease, specific carbohydrate diets, you've heard of many of these, and these will be discussed later in the morning. So as we learn more about inflammatory bowel disease through observation, through research, we are able to take that back to the reason we're doing this, which is the care of patients. And if we do this in a very agile way, we can make real-time changes to the recommendations of care that are provided so that we can improve the care we can give to actual patients. And actually, taking this one step further, just a few years ago, a group came together, of which we're proud to be the Washington State representative. Currently, hopefully others will join us, to come together to really directly impact the care that is going on in inflammatory bowel disease. There are currently 52 medical centers representing 29 states in the United States. Again, Washington State is represented. There are actually 2 in England, so this is now international. Since it's called Improve Care Now, you can find it on the web, has made huge impact just in the last few years in outcomes in patients, children in particular, with inflammatory bowel disease, keeping folks in remission and getting them there if they were not already. The goal is to improve the care and the health of all children and adolescents with Crohn's disease and ulcerative colitis. We really want to partner with, engage, and empower patients and families to participate as true partners, informed partners in all aspects of your care, but also in the network so that we can learn more and we can continue to learn from you and improve the care we can provide. Through research that this group and others, of course, are doing, we want to transform the care and continue to discover so that we can continue to improve inflammatory bowel disease outcomes. And obviously, we would like to do this at the lowest cost possible, and this is especially important as our economy has struggled in the recent years. So this morning, I hope that you are inspired and you will be inspired even more as the day goes on. We have a very nice group of speakers, members of our IBD Center, who really want to talk with you and learn from you and impart to you some knowledge that you may not have, you may have, and then we can learn from you other things. What is inflammatory bowel disease? What are the current standard therapies? You know, why, if you recognize what medicines you are on, where does that fit in the whole rubric of what we have available? We want children to have a normal lifestyle. We want you to go to school, do sports, do all the activities that you should do. Chokes me up just thinking about it. So how do we manage that despite the fact that you have inflammatory bowel disease? What is the role of food? This is very important. We eat it every day. What is the role of food? How does it influence our health? And what about those bugs that we don't see, but they're in there, and we need them, and maybe we can influence them, and maybe we can partner with them. And most importantly, you have IBD, but have fun and be a kid. So, I'm assuming there are no questions for me because I didn't really tell you a whole lot of new information. However, I do want to kick this morning off and introduce the next speaker. So he is a drum player. This is from Camp Oasis. It's actually a great pleasure for me to introduce to you my colleague and a dear friend, Dr. Ghassan Wahbeh. Dr. Wahbeh is actually plays a huge role. He's pretty quiet. He's a lot of fun. He's quite a musician, as you can see. I also have a picture of him playing the guitar, but but he also is really trying to impact inflammatory bowel disease in a very significant way and drive things forward, not only taking care of patients. He's on the board of trustees of the CCFA. He's a chair of the medical advisory committee of the CCFA. And in partnership with Teresa, he co-directs Camp Oasis. And I'm very proud to say that he last year was the recipient of the CCFA Mike McCready and Ashley O'Connor Award, which was a very high honor. So with no further ado, Dr. Wahbeh.
It's wild because every year more pictures show up and I had no idea that they were taken. So I don't know what's in store for next year. Thank you so much, Dr. Murray, for this kind introduction. It's important to keep in mind that you can put a lot of team members together and you can get the expertise together, but you need leadership. And I have to credit Dr. Murray with pushing our center to higher grounds, time and again, and for all the support that she gives all of us. And without that, I don't think any of our work would be possible. So thank you for the work that you do. So let me just pull up my talk. So over the next 25, 30 minutes or so, I'm going to go over the definition of what IBD is all about, and then try to answer some of what we know and maybe some of what we don't know about IBD. Why does it happen, and what entails the process of having IBD? So IBD, or inflammatory bowel disease, is really a general term. What it tells us is that this is chronic inflammation. So if you take the word inflammation and break it down, inflammation is a natural response of the body to some event. So it's usually a very meaningful process where our body tries to fight something, get rid of a toxin, get rid of a substance, react to something like a bee sting. That's inflammation right there. So inflammation in general is actually a good phenomenon to happen. Except that when it goes on and on and on and on and on without a reason, that's when inflammation becomes more costly without having much of any benefit for the body. And the term inflammatory bowel disease denotes having that ongoing inflammation that has no purpose. And that happens in multiple parts of the body, as we're going to show. And depending on where it is and how it behaves, we call it Crohn's disease, ulcerative colitis, or a blend of both. And the term for that is unclassified IBD. And as you've seen from Dr. Murray's talk, IBD has been on the rise since World War II. And that goes hand in hand with many conditions, allergic conditions, as our allergy specialists know. And it really raises a lot of questions about why. This is not just that we got better recognizing IBD and general pediatricians refer patients to us early if they suspect IBD. It's a genuine increase in the incidence, especially if you look at the 70s, 80s, and then compare that to the 90s and the beginning of the 21st century. And you've seen this map as well. IBD is a disease of what is termed developed countries, where life is cleaner, if you will. And this really fuels a lot of theories about etiology. And this is where sort of, you look at the numbers of cases of IBD, and you generate a list of what is different about these countries where IBD is high, and why should it happen in these areas and not in others. And a little example of that, if you look at Japan, for example, if you look at big cities like Tokyo, the incidence of IBD can be relatively high, approaching the incidence of IBD in LA. If you go to some of the villages where industry or mass production or the idea of not having fresh food is not there, so you have a fresh market, you have food that is not packaged or processed, and the incidence of IBD in that area is different. Same thing applies to small towns and big towns in India, for example, Korea. So some of the theories that you heard about already, the hygiene hypothesis, came up because of this. If you have life that is cleaner, your body is not constantly exposed to bugs on a daily basis. And as you heard, bugs live in our bodies. So we have more, if you will, bug cells than our own body cells. And we live in harmony with these cells. Except that in IBD, this relationship does not seem to be that healthy. Now, the fact that we're constantly exposed to bugs, fighting maybe worms or worm eggs that transit through our bodies without causing harm. Sometimes they do cause harm, but oftentimes they don't. So when your immune system is busy all the time, fighting little things here and there, it seems like this is a good thing for a lot of individuals, because when the immune system has free time on its hands, it seems to fight its own body cells. And that's when inflammation that has no meaning begins. So that's the example of why the hygiene hypothesis comes up. Another hypothesis that, again, simply driven by maps of IBD incidents like this one here, is the refrigerator theory. In a lot of countries where you have access to a refrigerator, so you keep food longer, the incidence of IBD is higher. So again, you drive a theory that says the fewer items that are fresh that we get might change the way that our bodies interact with that food structure might be, the bacteria in the food or the food effect on the bacteria. All these things might change if you have food that is just picked up from a farm that day, or food that has been packaged for a week or two, or some freezers, you can keep stuff for 6 months or a year or longer, right? So another theory behind that. Another one too is the canned food theory. So if you have food that is, again, preserved and sitting in a can for a long period of time. So it's not to say that one thing causes IBD that these theories suggest. And it's important to keep that in mind. So it's not like you have that corn out of a can that caused IBD for you or your family member. But again, it's sort of the general way that our interaction with food, bugs, and the environment changes the way that our immune system works, and that what results in IBD. So again, if you look at the genes, we know about 30% or so of the genes that have some association with IBD. So it's not to say that we know a lot about the genes. And as of today, there are more than 200 genes that have been linked to IBD. Now, just to break it down a little bit, what genes do is they produce a lot of the mediators or chemicals that handle the inflammation and the behavior of the immune cells in our bodies. So if you have genes that are predisposed to having your immune cells be overactive and overwatchful, then these genes, if they're active or they're loud and pumping these proteins, then you're more likely to generate inflammation for no good reasons. So knowing that there are 200 genes perhaps does not help us a whole lot. 200 genes, and each of these genes is linked to some risk of IBD. That may not help us a whole lot, because if you test negative, you still have about 70% of all patients that have no identifiable gene for IBD. Now, you also have to look at it and say, if over the past 60 years, we have not had a major cosmic event that somehow changed all of humanity's genetic structure, then the genes have not changed really that much over the past 60 years. So driving the hypothesis that a change in human genes is what drove IBD seems to be a little weak. So we have to think about what is it about the immune system then that allows IBD to happen if it's not a massive genetic change. And that's when maybe more and more focus comes to the environmental factors that predispose to IBD. In other words, the gene is there, but it's silent. And if you look at some of the new information that we're learning, for pretty much any average healthy human being, we have 400 genes that are predisposed to some kind of disease. But for the majority of us, these 400 genes are silent. They're not doing much of anything. They're controlled. But we know that we have some genes that are ready to behave in a abnormal way at some point in time. So if the right environmental trigger happens and these genes are woken up, then they change the way that the immune system works, and that's where we end up with IBD. So another angle to look at to explain why IBD happens is this. So if a normal individual, healthy individual, has a bug or food poisoning, the natural response of the body is to fight that bug and try to wash off all of that toxin that comes with that food poisoning. It's a good thing, right? Nobody wants to have food poisoning. Nobody wants to throw up and have diarrhea. But for a few days, the vomiting and the diarrhea serve to wash off that bug and that toxin out of the body. And a smart immune system is able to stop that process. After 2 or 3 days, that's it, the bug is gone, the toxin is washed off, end of story. We need that immune system to go back to its baseline of being balanced. And this is what happens in a healthy individual. But in the presence of the genes that predispose to chronic inflammation or IBD, this inflammation process does not stop. So the body continues to think that there's a reason to keep that inflammation going, and it does not stop it. And that's part of the problem why IBD continues. And it's also part of the reason why we use anti-inflammatory agents to try to balance that overactive immune system that is unable to stop. So to look at it from a different angle, some of the genes that we've identified so far have to do with this little protein here. It's called a toll-like receptor. So what we're looking at here is intestinal cell, and this is the lining of the cell. This is the inside here of the, I should use the mouse. Can't find the mouse. So this is the receptor protein that recognizes that the bacteria that live inside the lining of the intestine is actually good bacteria, not an enemy, and that the body should live in harmony with this bacteria. So again, this is the cell lining, and this is the inside of the cell. Now, some of the genes that we identified show us that the protein here is not doing a good job recognizing that the bacteria right next door is actually good and friendly bacteria. So if this relationship between the receptor on that cell and the bacteria goes bad, that's when all these consequences start up, and these consequences generate the drivers for inflammation that start inviting inflammation cells or inflammatory cells, lymphocytes and neutrophils, macrophages, and these cells start causing the inflammation and destroying the lining of the intestine and maybe the wall of the intestine. So that's only one theory out of many, many theories that we so far recognize, and that's thanks to advancements in the genetic studies and the biochemical studies in IBD that led us to recognizing this part. Now, we also know that this is not the case for all patients. So this might explain IBD for maybe a third or 1 out of 4 patients. Now, I go back to the genes again to focus a little bit on it. And what we're looking at here is actually twins. And the twin on this side has IBD. And you can see that because of several reasons, whether it's delay in diagnosis or the inflammation not being adequately treated, you see that the Crohn's can affect the growth for that individual compared to his twin brother in this picture. And surprisingly, if you look at Crohn's disease for identical twins, now identical twins have the same identical set of genes, and as children, they're very likely to grow up in very similar environments, right? They probably have the same food, they live in the same temperature, most likely if they travel together. So there aren't too many differences between identical twins, especially in childhood. Despite that, for Crohn's disease, which is this bar here, it's only 50% of the time that both twins have the disease. And in fact, newer data suggests that this number is actually around 35%. So it makes it even more of a statement to say that the gene hypothesis is not enough on its own. So there must be some subtle differences between these identical twins that makes one twin set of genes act up and the other twin's identical set of genes not act up, and therefore one has IBD and the other does not. Now, we also know that it's important for us as pediatric specialists to recognize that 1 out of 4 children, which is this part of the bar here, of the graph here, sorry, present in childhood under the age of 18. And that's why we want to try to capture the inflammation and the diagnosis early on to treat it effectively early on and improve the outcomes later. Another graph to show you that the incidence of IBD has definitely increased not only in adults, but also in IBD. So the burning questions on all of our minds is what really predisposes to IBD? We know about the theories. Do we know about actual factors that relate to our environment that predispose to having IBD? And this is by all means not to say that this item or that item causes IBD, and I want you to know that. It's very important to recognize that as well. As of today, we do not know of any single antibiotic that causes IBD, a single food that causes IBD, a single exposure or lack of exposure that causes IBD. But all of these are, I think, small components of the bigger picture of environmental triggers that add to the risk, not cause, but add to the risk of developing IBD. This was an interesting study from Germany, and they looked at exposure to farm animals. That if you, in the first year of life, have some exposure to farm animals, and there's a difference between farm animals, between farms. So, you have animals that live a healthy, happy life on a farm, and you have animals that live in a very unhealthy condition on a farm as well. So again, I don't want you to generalize. And actually, if you travel in Europe, and I know a lot of you have, a cow sitting on a massive area of grass in Switzerland is different than a cow that has barely 3 inches from the next cow in a meat factory, if you will. So difference there by all means. But if you're exposed to animals, farm animals at a young age, you seem to have a lower incidence of allergies and IBD. It doesn't apply to pets, okay? Another study, and this came from one of our colleagues, Dr. Kronman from Seattle Children's Hospital, where he looked at over 1 million records of children in Europe and the risk of IBD if they were exposed to antibiotic in the first year of life. And receiving some antibiotic in the first year of life seems to also impact the incidence of IBD. Again, it doesn't mean that the antibiotic causes the IBD. And within the same paper, it's actually important to keep in mind that for certain diseases or infections, it's actually harmful not to receive the antibiotic. Simple things like ear infections, for example, if they're untreated, they could cause deafness. So it's not to say that you should not use antibiotics when you need them. This is to say that if you can avoid using the antibiotic, so minimize the use of antibiotics and use them for the right reason and only for the right reason, that unnecessary use of antibiotics can add to the risk of developing IBD. Another study from Canada looked at exposure to different food components and maybe some association with IBD. And they suggested that kids who receive more fruit, vegetables, fiber in fruit and vegetables, fish, and it's not fried fish, it's really oily fish that is minimally cooked. We know that not everybody has a taste for that. And then omega-3 fatty acids, which can come from, for example, olive oil, certain nuts, and fish oils, again, unprocessed fish oils. That there's also a slight maybe protective factor for consuming more of these items rather than animal protein or processed foods. So I know I have 5 to 7 minutes here, but the end point of having the inflammation is number one, showing the inflammation in different parts of the gastrointestinal tract. And we know that Crohn's disease can occur anywhere from the top of the gastrointestinal tract all the way to the bottom of the gastrointestinal tract. Crohn's disease involves all 3 layers of the intestinal wall. Ulcerative colitis is limited to the large intestine or the colon, and it involves only the innermost layer of the colon, which is what we call the mucosa. And the result of having the inflammation cells invading the lining of the intestine is what we know commonly occurs in IBD patients. And there are different combinations of symptoms. So pain, diarrhea, weight loss, growth impairment. Some Crohn's patients can have infections or inflammation around the very bottom end of the colon. And there are also extraintestinal manifestations. The lips, for example, the joints, the eyes, and this is not common, but it's something that we always look for in our patients who have IBD. And it's also very important, I know Dr. Cunningham will address this further later on today. It's very important to keep in mind that at least 1 out of 3 of our kids with IBD will have some degree of anxiety and or depression. Nobody wants to have anxiety, of course. Nobody wants to have depression. But this is part of the inflammatory process that comes at the same time with the inflammation. And it's important to recognize that, not just for the kids, but for the parents. And it's part of what we focus on in our IBD program. So as IBD presence affects a lot of processes in the body, it's important to keep in mind that if you look at a child who has IBD, as these processes go through, IBD can influence each and every part of these developmental steps. And that's a big reason to say we need to effectively treat IBD during this age group. It's not the same as looking at a 25 or a 30-year-old individual with IBD. So growth, puberty, social development, emotional growth, attending school, and then building bone density. All these processes that happen mainly between the ages of 10 and 20 years, if they're interrupted by the inflammation, it's difficult to make up for them. And that's why whatever we do for our patients, we have to focus on effective therapies that prevent these processes from being interrupted at that age group. And this is a graph that shows you what bone density is all about. So bone density, in short, is strength of the bones. And as we grow, it's like a bank account that we're born with. And over time, over 20 years, we try to deposit as much strength and density into that account as possible. And up until the early 20s, late teen years, we get to a maximum. Then all of us, all human beings, will start losing bone density with time. Okay? Now, if you start low because of the inflammation or uncontrolled inflammation interfering with the bone density buildup, then you can imagine that if you start low, then you're going to end up with a low bone density later on. And that predisposes to fractures with time. This is a painting from one of our patients who was 8 years old when she told us that IBD feels like this to her. Isolating, lonely, and a huge degree of worry and maybe silence. And it's really touching to see that perspective from an 8-year-old with IBD. Internally, this is what IBD looks like. This is the colon. The colon should look like the inside of your cheek. So pink color, smooth. You can see that there are a lot of breaks in the colon, and some of the white substance here is actually pus. And Crohn's disease looks like also a lot of ulceration with some of that pus. And this is a healthy small bowel portion. This is the stomach. This is the door out of the stomach. And you can see little sores here caused by Crohn's disease. under the microscope, and this is one of the maybe hot questions in IBD, for about 40% of patients with Crohn's disease, you can find what we call a granuloma. And a granuloma, which is seen here in this big lump of cells here, is a number of inflammation cells or immune cells trying to fight something. And this is one of the hot questions in IBD, is what is that something that they seem to be fighting? You know, keeping in mind that it's present in 40% of patients, not all of patients. So where are the future directions in IBD? One is we need to continue to understand better and better what is the exact mechanism behind IBD. As I told you, there are a lot of genes, but we want to try to understand is what makes the genes turn on, how do they affect the immune system when they're turned on, and how does the environment, whether it's food or bacteria, interact with that immune system to start the process of inflammation and not stop it. So it takes us also down to changing either the immune system or the bacteria or the antigens, which are food particles that go in our body. And how does that relate to IBD treatment? And you'll hear about that from my colleagues later today. And we want to learn how to prevent IBD. If we know a certain individual has a family history of IBD, what do we tell you as the family about siblings or your own health? What can you do to perhaps prevent IBD showing up in relatives? And then better treatments. We know that the treatments that we have are not ideal. They come with their share of side effects. We want to explore newer therapies, nutritional therapies. Again, you'll hear about that later today. And last but not least, we should never forget that the ultimate way to treat IBD is to find a cure for it. And we should always keep that in mind, that all of this work must at some point in time end in finding a cure for IBD. Thank you. So next, it's my honor to introduce the next speaker, my colleague, Dr. Namita Singh. And I've known Dr. Singh for just about 3 years now. She trained in pediatrics at UCLA. And luckily, we got her back from California up to Washington State to join our training program. And she has been an exceptional provider. She has shown a lot of interest in inflammatory bowel disease and has actually dedicated a good chunk of her training for IBD, which is something that is not often done in training programs. Namita has a lot of enthusiasm for IBD. She delivers exceptional care for her patients with IBD. And she had been, and has been, sorry, a key member of one of our projects where we're trying to improve the way we effectively treat our patients who are in the hospital with IBD. She also has a lot of interest in the microbiome, the bacterial therapies for Crohn's and colitis. And she's one of the pioneers in the nation who's forwarded that work. So Dr. Singh will give us a very informative talk about medications in IBD, and I'm honored to have her speak today.
Thank you so much for that kind introduction. All right, so I have the pleasure of speaking with you today regarding the different medications that we use for IBD. Why are some of our kids on pills, and why are some of them on IV infusions, and why are some on both? Before I start, I do want to make it clear that I have no disclosures, I have no affiliations with any drug companies, so I'm not advocating for the use of one drug over the other during this talk. I will be speaking regarding medications using their generic names, as well as their trade names or their brand names for your familiarity, as you may know your medications as one or the other. So the goals over the next 20 to 30 minutes are to really understand the goals of treatment with our medications that we have available today. We also want to emphasize the individualized approach that we take to treating our patients with IBD, as no two people are the same and thus no two diseases are the same. We also will talk about the different stages of treatment and what remission entails. And we will talk about some of the medications that we use, including their indications and side effects and how they work. So what are the goals of treatments? Why do we treat IBD with medications? One is to improve your quality of life, and we want you to be feeling better. We want you to not have as much abdominal pain, diarrhea, vomiting. We want you to be active in school. We want you to be participating in sports. We want you to go on to go to college, have your own careers, and not be limited by your disease. We don't want you to worry about where the closest restroom is all the time. We also need to restore growth. An inflamed intestine means that your body is inflamed. And when your body is inflamed, then you're not achieving your maximal growth potential. So with decreasing the inflammation and with medications, we'd like to restore your optimal growth. We also want to avoid you coming in the hospital as an inpatient, just as you want to avoid coming into the hospital. When you're in the hospital, that means that your disease is acting up or you may have a flare. Also in IBD, we like to try to avoid surgery, especially with patients in Crohn's disease. Of course, sometimes surgery is inevitable, especially with some complications. And in that case, we have a great relationship with our pediatric surgeons here, and we're very happy to refer to them when necessary. However, we'd like to hope to prevent this point. Also, we like to avoid the recurrent use of steroids. Steroids are good medications, and they act quickly and really help many patients. However, we know that the long-term effect of steroids can be bad, and we'll review some of that. And thus, we really want to limit the amount of steroids that your body sees over its lifetime. So medications, and more medications. While there's currently no cure for IBD, we do have a number of medications that really help to control the inflammation and relieve your symptoms. The symptoms might be pain, diarrhea, or more. The treatment that you're on depends on the severity of your disease, possible complications such as fistulas or narrowings in your GI tract, and your prior response to therapies. It's quite possible that if you look to the left of you and you look to the right of you, your other patients may not be on the same medications. That's because many diseases vary in their severity and their location. What are some medications? Well, there's prednisone, mesalamines, methotrexate, Humira, Lialda, Azicol, Remicade, Cimzia, and more. Those are just a few. So there's tons of medications, and the goal is really not to memorize all these medications, but to really put them in broader groups or classes and to understand how they work and how we give them. It's also important to note that there's really not a one-size-fits-all approach. Here we see a pyramid, and at the bottom here are some of the more mild medications, such as 5-aminosalicylates. And over on the left are some of the names that you may be familiar with. Just above that are corticosteroids, such as prednisone. And above that are immunosuppressants or immunomodulators, such as methotrexate, 6-MP, Imuran, azathioprine, and at the top are biologics or anti-TNF agents such as Remicade, Cimzia, and Humira. Many, many years ago, we used to use the step-up approach, meaning that we would start with the more milder medications, and if you failed that, then we'd work our way up the pyramid. However, many people a number of years ago said, stop, what are we doing? Why are we allowing all this inflammation to continue? Let's really start at the top and really treat the inflammation as best we can. So what are we doing now? Well, the easy answer is that it depends. It really depends on how you present, the severity of your disease, and where it is. So some of you may be on some of these medications, and some of you may have started with these medications. So what exactly do these medications do? As Dr. Wahbeh pointed out, in IBD, you have an excessive immune reaction, as well as an excessive inflammatory response. So these medications really aim to suppress the inflammatory response as well as suppress the immune system. The goals of treatment are to achieve remission and to maintain remission. So what does that mean? Remission means that you're feeling better. It's the absence of symptoms. We also like to see that the inner lining of your intestines or the mucosa is healed. It doesn't have ulcers or the pus that it had before. And what is maintaining remission? Well, that means that once you feel better, we want you to keep feeling better. We want to avoid the flares, avoid steroids, avoid having you come to the hospital. So there's different stages of therapy and different medications used within those stages. So to induce remission, we often use corticosteroids, we use aminosalicylates, and biologic therapies. To maintain remission, we'll use aminosalicylates also, immunomodulators, and biologic therapies as well. So we'll be speaking first regarding corticosteroids. So what are steroids? Steroids are hormones that your body produces, and they really regulate and decrease the inflammatory response. And they're involved in the immune response as well. Sometimes we also give you these in pill or IV form. They're very powerful medications, anti-inflammatory, immunosuppressants, used to really induce remission. These are really quick acting, and about 80% of patients will start feeling better within days of taking them. They're available in oral form, IV form, and in rectal forms. The oral forms that you may be familiar with are prednisone, prednisolone, Entecort, budesonide. The IV forms are usually given in the hospital when you're first diagnosed or when you have a flare. That includes methylprednisolone or hydrocortisone. And there are rectal forms as well, such as cord enemas and cortifoam. So what are some of the side effects of medications? Like all medications, steroids do have side effects. One is high blood pressure, rounding of the face, or we call it moon faces. You can have increased appetite and weight gain, which actually may be a good side effect, especially if you've lost a significant amount of weight. You may have acne, mood swings, some emotional lability, and you may have an increased energy level, which again might be a good side effect. It may allow you to participate in your normal activities or go to school, but it also may cause some difficulty sleeping. And over the long term, we know that patients on steroids do develop some bone weakening or osteoporosis. And for these reasons, we really try to limit the amount of steroids that we give you. So it's really indicated for short-term use. Many of the times when we give you steroids, we'll start at a higher dose and have you wean down or taper the dose gradually over weeks. Many of these side effects you'll have more with the higher doses, and as you come down on the dose, you'll notice that the side effects go away. The next type of medications we'll discuss are the aminosalicylates, which are most often used in ulcerative colitis. These all contain 5-aminosalicylic acid, or 5-ASA. They're given orally or rectally, often 1 to 3 times a day. They're used to induce remission and maintain remission in patients with mild to moderate ulcerative colitis, as they work in the colon. And the way they work is that they provide topical relief in the intestine to decrease inflammation. You can think of them as a very soothing lotion that coats your intestines. Very little of it is absorbed in your blood system, in your blood. So what are some of the names of the medications? One is sulfasalazine. There's a number of oral mesalamines that you may be familiar with: Azicol, Delzicol, Pentasa, Apriso, and Lialda. And there's rectal mesalamines such as Roasa, enemas, and Canasa suppositories. There again are side effects, although with these medications, the side effects are often very few, but you can have abdominal pain, some increased cramping, nausea, headaches, and dizziness. And like with all our medications, we like to keep a close eye on your labs when you're on them. So this is a picture of the colon. Your small intestine would enter here, and this is your colon or large intestine. And it goes up, across, and down, and ends with the rectum. Many of the oral forms of these medications will act actually throughout the colon, sometimes more in the more proximal portions. The liquid enemas may reach all the way through the distal portion of the colon, and many of the suppositories really act locally in the rectum. Next, we'll speak regarding some of the biologic therapies, and we'll spend some time going over what the differences are. So the biologic therapies are used to induce remission and to maintain remission. They're made from living organisms and purified products such as proteins and genes, and they really act by stopping inflammatory proteins that cause inflammation from damaging the intestines. You may be familiar with some of the forms. There's an IV form, infliximab or Remicade, and natalizumab or Tysabri. There's also injections under the skin that are given. One is adalimumab or Humira and certolizumab or Cimzia. These are some pictures of the anti-TNF medications. 3 of these are Remicade or infliximab, adalimumab or Humira, and Cimzia or certolizumab. And you see that they all look quite similar. Remicade is made of 75% from human protein and 25% from a mouse protein that's purified. Humira is made 100% from human proteins, and Cimzia is similar to Humira, but it also has the addition of a pegylated portion, which allows it to stay in your system longer, meaning that you need a larger frequency between. So what is TNF? TNF causes your immune system to attack healthy tissues and your GI tract, causing damage and inflammation. And these anti-TNF agents recognize the TNF and they bind to them before they have a chance to bind to your GI tract and cause harmful effects. This was a video. It's not. I tried playing and it's not playing, but you can imagine that these are small TNF molecules all around all in your system, and these agents look familiar. They're those anti-TNF agents. They actually bind to the TNF molecule, so it prevents them from having their harmful effects. So what are their side effects and risks? Well, we know that you can have reactivation of latent tuberculosis, and this is why we always make sure that we know your TB status prior to giving these medications. If we don't know, then we'll check a blood test or a PPD. We also, we also like to make sure that we have all your vaccinations updated before starting therapy as well, as you can have suppression of your immune system, making you more prone to infections. There can be nervous system effects, which are often reversible with removing the agent, and there is a slight increased risk in lymphoma. Other side effects and risks include loss of response, meaning that your body stops responding as well as it may have to the anti-TNF agents, and allergy. And just like the other medications, these medications also require close laboratory monitoring. So what are some of the agents? So in specific, we have Remicade or infliximab, and we saw that the molecule was 75% human and 25% of mouse protein. It's given by IV infusion, usually every 8 weeks. And because it's given by IV infusion, it needs to be given at an infusion center or in the hospital to monitor for side effects. Some of the side effects include infusion reactions, which means that you may develop trouble breathing or a rash, and that's why it's so important to have this done in a place where you're really supervised. And also to note, about 10% of patients lose response yearly to Remicade or infliximab. So it's not that uncommon. Second, we have adalimumab or Humira, and we saw this molecule also. It's given by injection every 2 weeks. So the plus is that you can give these injections yourself at home. You don't need to go to infusion center. Cimzia is similar to Humira, but it's given every 4 weeks because it has that delayed excretion from your body from the pegylated portion. Oftentimes, we'll have you check with your insurance company to find out which of these two medications it covers better. Next, we'll move on to the immunomodulators. So what are these? These are some names that you might recognize: azathioprine, Imuram or Azason, 6-mercaptopurine or 6-MP. And these medications are used to maintain remission. And they're used to maintain remission because they have a slow onset of action. It can actually take months for you to have the full effect of these medications. For this reason, they're often given with steroids initially because steroids are quick acting and these are slower acting. These are in oral form and given once daily, and they do decrease the activity of your immune system, which then decreases the inflammation. Some of the side effects of these medications include headache, nausea, diarrhea. You may develop some rashes or joint pains. There is a possibility of liver toxicity and bone marrow suppression, meaning that your blood counts may become lowered, and pancreatitis. And that's why it's very important that you follow your doctor's recommendations of getting periodic labs to check for some of these. Others immunomodulators, which I'll mention, include methotrexate, which is given orally or by injection, tacrolimus or Prograf, cyclosporin, Neoral, and mycophenolate or Cellcept. It's also important to mention that these medications, you may be on one, you may be on a combination, and some of the combinations do have a synergistic effect. So we've reviewed some of these medications here, and it's also important to note that there is ongoing research currently, and we will have new medications coming out in years. And hopefully these new medications will have fewer side effects and are more tolerable also. And as Dr. Wahbeh pointed out, we are still working on an ultimate cure for inflammatory bowel disease. So in conclusion, we understand that the goal of the medications are to induce remission, get you feeling better, and to maintain remission and keep you feeling better and keep you from having flares. We know that the medications that you're on may change over the course of your disease, depending on you and your body's response. And each medication has its own side effects. Each are unique, and all of them actually require monitoring. So please talk to your GI providers, the nurses, your NP, PA, and your physicians. Love to share more information with you. If you have any questions, please feel free to contact us, because we know that a healthy intestine is a happy intestine. Thank you. I do have the pleasure next of introducing Dr. Carin Cunningham. She did complete her PhD at Kent State University and did her postdoc fellowship at University Hospital, where she worked for 10 years. Interestingly, she worked closely with one of the gastroenterologists there, who was actually Dr. Wahbeh's mentor. She served as a trustee for the Crohn's and Colitis Foundation of Northeast Ohio for 5 years, and she's done quite a bit of research in health-related quality of life in parents and families with IBD. We're lucky because she moved to Seattle 3 years ago, and she's currently attending psychologist in the Department of Psychiatry, and she's a very integral member of the IBD team here at Seattle Children's Hospital. Dr. Carin Cunningham.
I'm going to interject real quickly before we hear Carin Cunningham speak. Hi, everyone. I just wanted to introduce myself. A lot of you I know, and some of you I have yet to meet. My name is Deborah Jacoby, and I am the Take Steps Walk Manager for the Crohn's and Colitis Foundation. Who here has heard of Take Steps or already has a team signed up? Yes, this is great to see. I'm a great crowd. If you are wondering, what is Take Steps, or how do I get involved? Seems like a lot of other people are excited about it, which they are. I am happy to tell you about it. So Take Steps this year falls on June 1st. It's a Saturday. It's at 3 p.m. and it's at Magnuson Park in Seattle. So obviously very close to here. So if you can make it here, you can make it there too, hopefully. And it's just a really fun festival day. We have all kinds of different activities, live music, lots of things happening, and a beautiful about 2-mile walk around Magnuson Park. I have these little blue sheets out front on the Take Steps / Team Challenge table, which is another great program we have. So these little blue sheets out there, if you want more information, want me to send you an email or have coffee or just talk a little bit more about this amazing program, please leave a little note for me, and Kathleen will make sure that it gets to me after the day is done. And Teresa, did you want to plug as well? Yes, great. So, great. So anyways, again, thank you so much for coming today, and I hope that I get to see you on walk day. It's going to be a great day. Thank you.
Okay, I'm Teresa Walks. Welcome. Now the real fun's going to begin. So, kids, if they're for our older kids or even the younger kids, if you want to stay, if you've looked at the program and you want to stay and listen, that's great. Otherwise, we're going to go down the hall and have a great time. We've got good music going, and we've got stuff going on down the hall. So we'll have the kids go, but before you go, I just have to say one thing. If you're thinking about Take Steps, you can sign up for our team. Children's Champions, you can sign up online and be part of our team that walks. Now, I know some of our kids have their teams, and Lucas, where are you? What's your team's name again? Lucas. Where's Lucas? What's your team's name? Lukey Dookie. And do you have a team this year? Or you could walk with us there, Lucia? Anyway, so... Oh, Ethan, you've got a... Where's Ethan? Oh, there you are. So Ethan has a team, but I got the microphone, so I want you to sign up for our team. So if kids, yeah. Oh, yeah. So kids, if you want to go back, Heidi Zagorski, raise your hand. She's my other nurse partner in crime there, and we'll follow her. And then adults, you know, after the kids leave, you're not going to be so many. So if you can see that we're really nice. So if you want to move a little closer, we're not going to call on you and ask you hard questions or anything. So if you want to move down a little bit more towards the front, that would be great. Oh, and also we found out that the bathrooms this way have lots of stalls, as opposed to that ones down there only have 3. So it sounds like bathrooms to your left are your best bet. Okay, so we'll be right down the hall with your children. Okay?
Did you email it to them, or did you bring it?
No, I emailed it to her, so chat.
I wonder who we should ask. Who is doing
It wasn't.
I mean, it's
Did you
here.
bring-
It's
oh, it's
plugged
there.
in, but it's in this. But she emailed hers to Chad.
Oh, I see.
So,
What is it called? Let's see.
do you have it in?
Living with IBD. This is it. Number 5, yeah.
Yes, ma'am.
And Ghassan, this over here, right? Yeah. Hi. Now that we've got a smaller group, I'm Carin Cunningham.
clinical psychologist, and I know some of you here. I'd like to shift gears from talking about the cause of the illness and medications and to really focus on how you function with this very complicated illness. I think it's important for you to realize that the team here, their first priority is your child's medical care and doing the best job they can in terms of medication and helping your child feel well, but they also see your child as more than their GI tract, and that your child is a person who's developing, and it's a really hard balance to manage that development and dealing with this complicated illness. So let's begin. Today I'd like to talk about the effects of IBD on the family, to examine the impact of IBD from a developmental perspective, and to present some lifestyle strategies that I think can benefit patients and families. So why am I interested in presenting a family perspective? The reason is as you all well know, that a chronically ill child affects all members of the family, parents, siblings, and grandparents. And children really learn to cope with their illness within the context of a family. Thus, how the family deals with and manages the illness is how the child sees they should proceed. Research has consistently documented that family function affects the psychological outcome of the chronically ill child. So this is not to put another pressure on you that, oh my gosh, now my family functioning has to be perfect so that my child can cope with IBD. Rather, it's to understand that what you do as parents and caregivers really has a huge impact on your child's response to IBD. There are many concerns of parents, and this is a hard illness to deal with. One mother reported to me, I know stress is bad for my child, but I can't prevent the stress, and I feel pressured to try and do it. And it's like trying to prevent life from happening. You can't do it. Parents worry, in addition to these aspects, they worry about the cause of the illness, that it's not clear what it is and what they should really pay attention to. And they're also worried about the course of the illness. Now, my child's doing well now, but what happens if this is going to happen? Or that you can't predict the actual course of the illness. How many of you worry about your child being teased because of growth retardation, special diets, or missing school? Yeah, okay. How many are worried about health insurance being difficult to obtain for your child later on? Yeah, that's even more complicated in our climate today. And then fears that IBD will lead to cancer. Now, you heard about some of the side effects of the medication. That's a real concern for many families. So what we have here is a balancing act, coping with IBD and all the demands. I mean, listening to all the different illnesses, to listening to what needs to be done and when, and every 8 weeks, infusion, and taking time off from school, but also letting the child function normally. So parents must be vigilant regarding physical care and yet not be intrusive. So you want to know what their stooling is like, but you don't want to stand outside the bathroom, and you don't want to interfere and constantly ask them. You want to let them learn to navigate at school by themselves, on the other hand, without a 504 plan, or without special accommodations that are needed for bathroom use or for taking medication. It's really hard. And you want to give attention to the child with IBD, but not at the expense of the other children in the family or of a spouse. And it's very easy to stand here and say these things, but these are really difficult issues. So this was a study I did in Cleveland where I looked at disease activity of the child and also looked at the child's health quality of life as how it affected parents. And as you can imagine, it's pretty intuitive that children with higher quality of life had parents who had a higher quality of life. When your child is feeling well, it just really feels good, and you're feeling, that whole area of stress isn't there. Greater disease activity was associated with lower parent quality of life in the mental health and physical health domains. So what that means is when your child is really having a flare or is feeling sick, your mental health and your physical well-being is more at risk. And this is the take-home point from this study. If your child is going through a difficult time, an exacerbation, parents need extra support, and they need to be very aware of their own health issues and their own mental health. And again, that's another pressure on parents, but I think if you're aware of this issue, it's important. So let's talk a little bit about siblings. How many of you have been concerned about the siblings in your family? That's a good number. Siblings, do not underestimate what they understand and what they've heard. Sometimes parents will think, well, we didn't really talk about that with Johnny or Julia, and they don't really know all the details, but parents talk on the phone to relatives, they talk to their neighbors, and kids overhear lots of different things. Siblings typically wonder, will my brother or sister be okay? Am I going to get IBD? Did I do something to make my sibling sick? Is it my fault? Will it help if I'm extra good? So sometimes you have a sibling who's like the perfect child. They don't do anything wrong because they're worried that they could do something that will only make their brother or sister worse. And of course, they're jealous that the sibling grandparents are really concerned. They get extra presents when they're in the hospital or when they go to infusions, or they get off from school when they have to be in infusions. Siblings are amazingly sensitive to what their brother or sister are feeling, but it's really important that you understand what they think IBD is, what they think their brother or sister's illness is, and why they got it. Because, as you know, children put together things in very strange ways. So they can hear one thing over here, and, IBD is caused by they wouldn't think antibiotics, a certain type of food, and then they'll be afraid to eat something. You really have to get very clear what their thinking is and what they understand. Despite the fact that these issues are very complicated, families report that one unexpected benefit is that there has to be increased communication because of the complexity of dealing with this illness, and that actually the increased communication has brought the family together. So I'd like to talk a little bit about the individual's response to IBD, your child's response. I could spend an hour talk on each one of these different factors. I'm not going to, but I'll just quickly mention that social support is important. IBD severity, some children have really severe disease, and of course that has a huge impact on the whole family, and particularly the child. It's very different where if they have mild disease and they can go to school and participate in sports versus really severe disease. if you have an IBD team that is supportive and helpful to all the issues, nutritional issues, medication issues, psychological issues, daily stress. Some families just have more stress than others. That's just life, and you can't prevent that, as that one mother said. But I want to focus today on the impact of age and very briefly the impact of some psychological factors. Why a developmental perspective? And I think it's important to, Dr. Wahbeh alluded to it, that with his arrow where he looked at the impact of IBD at different developmental points. And it's important to know that developmental changes are evident in the brain throughout the lifespan. The most dramatic neurodevelopment occurs during childhood, and it's guided by an interaction between genetic programming and environmental factors. And as the brain develops, so as our thought processes develop from young children, we also develop, children, as you well know, develop certain skills, certain abilities of things they can do. Every basic skill necessary for adult functioning matures during childhood and adolescence. So at the same time your child is learning these basic functional skills and their brain processes, their cognitive functioning is developing, they're dealing with this complicated illness, and it's tough. So let's talk about development in young children. Young children being ages approximately 2 to 6. In terms of their cognitive or their thought processes, they are present-oriented, they're egocentric, and again, that it's really important that you understand that doesn't mean that they're selfish, but everything starts from themselves and then goes outward. You cannot ask a child ages 2 to 6 to, now, don't you think that Johnny's going to get upset if you pull that toy away? They literally can't put themselves in the place of somebody else and imagine what it would be like. They don't have that perspective. They're beginning to tolerate separation from the caregiver. The IBD-related concerns are fear of pain from diagnostic procedures, IV and blood tests, diet restrictions. I think that goes throughout the course of development. Diet restrictions are really hard for kids. The inability to cognitively understand their illness, it's really hard for a younger child to get what IBD is. And if a child has to be hospitalized at this young age, separation issues become very complicated. So then we go to school-age children around the ages of 7 to 12, and some of their skills, they learn to greater independence from parents, they form peer relationships, they can assimilate and understand information, and they can take the perspective of somebody else. They can put themselves in somebody else's shoes so that they have that greater understanding. This is just the time, though, when they're trying to master some type of independence. And it makes it hard because parents need to be involved in eating and toileting issues just at the time that the child wants to do this themselves. There are social pressures not to feel different because they can't eat certain foods. How many of your kids feel upset when they go to birthday parties and they can't eat certain foods or they can't have certain snacks? Just one couple, okay. And issues related to lack of growth and fatigue. Whose child is really upset by their lack of growth? Yeah, that's a bigger issue. Okay. So then we go to adolescence, and as we know, this is a tricky time without IBD. Adolescents are learning to navigate their own world, achieve independence. The good news is that their cognitive thinking has developed. They have abstract thinking. They can understand that something in the future is going to happen. But that makes it also complicated because, for example, some kids who may have to have surgery worry about the long-term implications. They're not just present-oriented. It's a mixed blessing. On the whole, though, I think it's a good thing because they can also understand from their physician what the illness is and what the treatment will be. IBD-related concerns have to do with future functioning, increased vulnerability to peer pressure, and this is a time when there's a lot of school avoidance because of bathroom usage. In Ohio, I did a survey of school nurses, and from Catholic schools, public schools, private schools, and a nurse from this suburban high school told me that kids would talk to her about drugs, sex, anything, but bathroom issues are so embarrassing and so private that that is really hard for them. And I think that that is particularly hard at this age. There's a history or there is a pattern of non-compliance with medication and diet. Have any of you experienced that? Where people, kids just don't want to follow the plan. They're tired of it. That's enough. And there's significant body image issues. And of course, all of this goes back to disease severity and some of the other factors that were in that circle. I'd like to talk a little bit about psychological factors in IBD. While Dr. Murray's slide looked at the impact of stress, it's really important to clarify that there is no data to support any psychological factor as causing IBD. Did anybody ever have that thought here? No. Okay, good. Stress can affect a patient's ability to cope with IBD, and I guess there's some thought that it can cause an exacerbation. I think that it's not really clear. What I am trying to do is get rid of a simplistic cause and effect that psychological factors or certain personality types lead you to IBD. Despite this lack of data, one study reported that 55% of patients with IBD are convinced that their own personality or stress is the cause of their IBD. Now, this did include adults, so it's a larger grouping. In terms of psychological treatment, there's no evidence for psychotherapy impacting the course of IBD. However, patients report that psychosocial intervention is helpful in decreasing stress and improving coping with their daily lives. While psychological help is not going to fix the course of their IBD or the illness, it can be helpful, and I would suggest that you think about it in these specific times when noncompliance with IBD treatment becomes self-destructive. Sometimes parents report finding pills that their child had sworn that they will take over time. And diet, it's very hard to be compliant with the diet, particularly as a teenager. When there's poor functioning in a variety of areas, including school, home, and friendships, and when there are signs of depression, such as changes in sleep, appetite, increased missed days of school, and just a general inability to have fun or to enjoy life, and feelings of hopelessness. If these issues are occurring, I hope you bring them to the attention of your physician, and maybe we can figure out some ways to work on them. I'd like to talk a little bit now about lifestyle issues in youth with IBD. And these are factors which I think you can actually do something about and which are shown to be really helpful. I'd like to talk about sleep, exercise, and relaxation. So, sleep. We all know what it's like when we haven't had a good night's sleep, when we're exhausted and we still have to be on. Sleep is really important to health and well-being. There are associations among sleep problems and key physiological health parameters, including the immune system functioning and the metabolic and endocrine regulation. And, you know, IBD being an autoimmune disease makes this particularly compelling. Sleep deprivation can affect a child's ability to engage with and learn from the environment, thereby delaying or disrupting maturation. So huge is an important factor. What are the sleep disturbances? Typically, it's poor quality of sleep, difficulty falling asleep, disrupted or fragmented sleep with frequent wakenings, and an inadequate amount of sleep. All of these issues are related to sleepiness during the day, inattention, and other cognitive and behavioral problems. Now, unfortunately, many sleep disturbances are often undiagnosed and not routinely assessed by clinicians. How many of you feel that your child has some sort of sleep issue? That's a good number, yeah. And one of the other issues, I see somebody here in the audience whose child is significantly affected by fatigue. And fatigue is very tricky. Is fatigue the same as sleeplessness? Is it, you know, it's hard to know. Is it a side effect of having the illness? I mean, is it a symptom of the illness? It can be presenting, but ongoing when the child is in treatment, it's really hard to know. Is it a sign of depression? So the sleep issues, I'd like you to be really aware of them. These are the consequences of poor sleep. And one of the most significant consequences is when kids get on that staying up late because they can't sleep, then sleeping in because they stayed up late and missing school, and that whole cycle starts. And once that starts, it's really hard to break. So you really want to avoid that. Sleep is a particularly important issue in youth with chronic illnesses. Chronic illnesses or chronic medical conditions increase the risk of sleep disruption, and evidence exists that sleep problems are more often chronic and persistent in youth with chronic medical conditions. We don't know the exact mechanism, but they may be related to underlying disease mechanisms, treatment regimens, such as side effects of the medication, or hospitalizations if the child is hospitalized and is woken up, you know, for vitals, sleep gets disrupted. It's important to recognize the bidirectional relationship between sleep and health, so that sleep affects your health and health affects your sleep. Sleep problems may worsen the chronic medical condition, and in turn, disease-related symptoms may contribute to sleep disruptions. So this is an ideal. These are healthy sleep habits, particularly for teenagers. I don't know if you'll get the avoid electronics in the bedroom, establish a curfew on messaging. Those are hard, and they can be tension producing. However, I would encourage you to look at the habits for all ages, a regular daily schedule, and an environment conducive to sleep where it's quiet, dark, and cool. And some attempt to cut the electronics before bedtime. I think it's really important. So now I'd like to talk about exercise. And as Dr. Frank Hugh from the Harvard School of Public Health has said, the single thing that comes close to a magic bullet in terms of its strong and universal benefits is exercise. Exercise helps with both physical and mental health. Let me just see if I can get rid of that. Where's the mouse? Here. Oh, okay. There we go. Thank you. And the benefits of exercise, for kids especially, there can be a sense of accomplishment, particularly if they've been sick and haven't felt well. They sleep better. Sometimes there's less pain, and there's enhanced satisfaction with all of these issues can thereby increase the child's motivation to do some exercise. Data show that regular moderate exercise increases your ability to battle the effects of the disease. It has a positive effect on both physical and mental well-being. So what if you're saying, well, my child doesn't feel well, they're exhausted, they're in pain, they can't go out and go jogging or exercising? We're not talking about that. It's important that you tailor a program to your child's current abilities, whether that's walking to the mailbox and back, and that you pay attention to the medication schedule and responses to treatment. It's really important to start slowly with achievable goals, because if they get discouraged, they'll quit. And if you can hook them by letting them see that they can do something, that is very self-reinforcing. The goal is to do as much physical activity as your body lets you do and rest when you need to rest. Now, that's a goal for all of us, but it's particularly important for your children with IBD. Exercise and depression. There are more and more studies now which show that a number of psychiatrists actually recommend exercise as a component of treatment for depression. It helps decrease anxiety, it increases well-being. It's not just a good idea. It improves mood, and the endorphins released improve well-being. It's an important adjunct to pharmacological therapy, and it doesn't matter how severe the depression is. It can be mild, and it will still have a positive impact. So finally, I'd like to talk about some alternative health therapies. And according to the National Institute of Health, 40% of Americans use alternative health therapies. And among them, mind-body techniques have shown the greatest increase. Just out of curiosity, how many of you are using alternative therapies? That can include diet, yoga, hypnosis, meditation. Okay, good. So that's really a large majority here. Mindfulness is that peaceful state where you're paying attention to your breathing and to the present, and it can really help the body relax. The use of mindfulness, there are a number of studies that shows that it actually decreases blood pressure, and it helps people relax physiologically. And we just discussed some of these specific therapies, and I think Nyla Gregory, the nutritionist this afternoon, will go into much more detail about the role of diet. How many of you use diet as an alternative health therapy here? So again, that's a good number. But more data is needed to determine how these alternative therapies impact the course of a patient's IBD. So it's one thing that they can make you feel relaxed and make you feel better, but we don't have any data that completely shows they're impacting the course of the illness. And I'd like to end today by making some suggestions for promoting good adjustment to IBD, and to telling you from my experience, most families handle this illness incredibly well. They are doing wonderful things for their children. It's just hard. The most important, and I didn't put it up here, the most important suggestion that I would have is to take good care of yourselves. And I mean physically and psychologically to the best of your ability, because the better you feel, the better you will be able to help your child. And that is really important. I think as parents, and I'm a parent, we tend to jump over ourselves. If a child is having a problem, we kind of leap to their issues. But it's really important not to go too far away from ourselves. Most children with IBD do well. They lead productive lives, have families, and follow occupations of their choice. Keep IBD in perspective. Again, your child is more than their GI tract. You know, even though it's all consuming, especially when you come here and we talk about all of this, they're a whole developing person. Understand the illness from your child's perspective, you know, and that goes back to looking at the developmental age of your child. Communicate with other family members, particularly siblings, because they're also developing, and you want to make sure that they have been brought along. And finally, communicate with your IBD team. Thank you.
Thank you, Dr. Cunningham. In a moment, we're going to break for lunch, but first I'd like to introduce Barb Watson. She's our Team Challenge Endurance Manager.
Thank you so much. Anybody here interested in going on a trip to San Diego in September? Oh, come on. Well, with Team Challenge, you can. Team Challenge is a fundraising program for the Crohn's and Colitis Foundation. It's also an endurance training program. So it's a program where we come together for 16 weeks and we train together as a team. And at the end of the season, you will successfully complete a triathlon. Information meetings start May 14th. Our first training is June 1st. And in September, the team will head to Tri-Rock San Diego to celebrate everything that we have accomplished all summer long. So I challenge you to grab a family member, grab a friend, and join the team. I'll be out in the lobby there while you're grabbing your lunch. So please come by and talk to us and learn a little bit more about Team Challenge. Thanks.
Thanks, Barb. Team Challenge is a great program. I just did it last season, and I completed a half marathon, and if I can do it, so can you. A lot of parents do it in honor of their children, so it's a great way to do something extra for your kids to help us get closer to a cure.